Good morning. Now I'd like to invite Anil Mantel for the talk on cloudy cornea at birth, always glaucoma or anything else.
Thank you. The title of my presentation is Cloudy Cornea at Birth, Always Glaucoma or Anything Else? To answer the question, is it always glaucoma? The answer is no. It may or may not be associated with glaucoma. It may be anything else. Even if it is anything else, it may be associated with glaucoma. So we should be very thoughtful about this and evaluate the child accordingly for the proper management. Giving an example, neonatal corneal clouding, which may be bilateral, it may be unilateral. Even if it is presenting at birth or present since the birth of the child had happened, the several factors are involved in late presentation to us, like the second picture here. It may be associated with primary congenital glaucoma or may be associated with several other anterior segment developmental anomalies or some syndromic association. So we should be thoughtful. The differential diagnosis is written here. From my 35 years of experience, I'll give some example to really go into the depth of the problem. Birth trauma is an important differential diagnosis. This child was referred to us after 2 hours of birth. History of forceps delivery. The referral letter noted that it may be congenital glaucoma, may require treatment. That's not true actually. Forceps application has given rise to injury to the cornea, given rise to corneal edema mimicking primary congenital glaucoma. We evaluated, treated the patient with mild steroid for a tapering dosage for about 6 weeks, and you can see the picture, how the surrounding cornea cleared and the vertical fold along which the cornea was molded is seen here. It is more common in the left side because of the LOA, left occiput anterior position at delivery. 2 other presentations where it was associated with birth trauma. Now, slit line examination and examination under microscope, gonioscopy, and intraocular pressure checkup should be done carefully to establish the diagnosis. Here is a presentation, very common differential diagnosis, CHED. The classic appearance associated with normal intraocular pressure, normal corneal diameter, and if gonioscopy is possible, it can be seen, and the increase in corneal thickness really clinches the diagnosis. It may be associated with congenital glaucoma, that is combination of CHED with congenital glaucoma, which is a rare entity, but it is possible. Now, even though corneal edema was there at presentation, this picture was taken and the diagnosis was mucopolysaccharidosis. You can see the clinical appearance here. Intraocular pressure was normal. The management was done by internal medicine specialist. A patient presented, I think, within 2 weeks of birth. Both the eyes were having congenital corneal clouding, which is more in the right eye, but if we see carefully, there is prominent Swalb's line and the classic features of Axenfeld rigor anomaly. You can see the upper picture at pre-op, the lower picture at 6 months after the operation when the cornea cleared, prominent Swalb's line is clearly seen. Even though corneal edema at birth, careful examination will reveal there is no iris. Clinically, iris is absent. It is clinical aniridia associated with congenital glaucoma. You can see here the dentate process. Unilateral congenital glaucoma. You can see right eye corneal diameter is more than left. If we see carefully, the lid and the S-shaped contour of the lid here and the caffeolate spot clinches the diagnosis. It is a neurofibromatosis with congenital glaucoma. Look at the corneal edema. We operated on the child, corneal edema cleared, and evaluation revealed extensive enlargement of the bony orbit, which is very classic of neurofibromatosis. This is the very advanced case. Now, This is the artist diagram, what anterior segment structures are involved in a case of advanced case of anterior segment dysgenesis. You can see, along with corneal edema, there is so much of change in the iris, and here is a situation. Corneal edema, iridocorneal adhesion, and lens was also touching the back of the cornea, Peters anomaly. Ultrasound is of great help in distinguishing several situations and clinches the diagnosis. This child was referred to us at the age of 3 months. Corneal diameter in the left eye was enlarged, corneal edema, and the referral note was the patient may be having congenital glaucoma for management. Actually, when we evaluated the child without anesthesia in the office, we saw in the left eye white glow in the fundus, and we suspected. The B scan revealed the intraocular mass, and it was diagnosed to be having retinoblastoma, was managed by our ophthalmic plastic surgery chemotherapy unit. Ultrasound biomicroscopy is of great help in most of the situation where it is associated with corneal edema and anterior segment developmental abnormalities in the form of iris cyst. It was managed accordingly. When established primary congenital glaucoma, the treatment is primarily surgical, neonatal onset glaucoma. I'm just giving few examples, 2-3 examples. And preoperative appearance, and you can see 6 months postoperative appearance, surgery improved the situation. Here is the picture. Habstri is seen. This child operated at the age of 2 weeks and completed 28 years of follow-up. Again, unilateral congenital glaucoma, operated. You can see the lower panel of pictures shows how dramatically the corneal appearance improved, and the picture was taken 2 weeks after the surgery. The child completed about 10 years of follow-up starting in 6th standard. Here is bilateral involvement more in the left eye. We operated 6 months postoperative appearance, showed dramatic improvement in both eyes, but you can see in the left eye, Habstri region is still having residual corneal edema. A child who presented with left eye corneal edema, diagnosed as other eye normal and this eye is involved. Operation was done in the left eye. The last picture shows 10 years postoperative appearance. In a case of this kind of situation, unilateral glaucoma, proper evaluation should be done to rule out the diagnosis that glaucoma is not there, but periodic examination may reveal the development of glaucoma in the other eye in the later period. So we should be very careful. Thoughtful examination, proper management is required, and lifelong follow-up is required for the management of these cases.